into the tissues and into the muscles usually as well, below the skin and the tissue under the skin. And that's a very severe infection, quite a serious one. And some of the studies have shown that when people have had that type of infection, a number of them have been taking these anti-inflammatory drugs, and so there's been a bit of a link. It's not very clear, but we are being safe and just generally recommend to our patients to avoid those in case there is a link that we're not really sure about yet. And the other feature that seems to make a difference is being able to rest the limb, rest yourself, and that seems to help recovery. Okay. We have some guidelines that we've developed in the UK. The BLS is the British Lymphology Society, which is our professional society of lymphedema therapists and doctors in the UK. And the LSN is our lymphedema support network, the equivalent of your group. And it was the LSN we have a very strong patient group in the UK. The chair is very similar to Margareta, and she made several doctors go into a room and come up with these guidelines for cellulitis some years ago, and we've got together with our society as well, and we have a joint group now which meets every year at our annual conference, and we revise the guidelines. We look at any new evidence and any information that becomes available, and the latest version of the guidelines we did last year, 2010, and those are available on those websites. They're on both websites, the LSN website and the BLS website, and you can access those if you're interested. They have a lot more detail on the types of antibiotics and things than I'm going to go into now. Having said all that, it has to be a consensus guideline. What that means is that we don't really know the best treatment, so we agree as a group of so-called experts looking at the evidence what the best treatment seems to be, but we don't have good research on this. So which antibiotics do we recommend? Again, I'm not sure whether you have the same ones. You probably do, but this one is our favourite one, amoxicillin, which is a penicillin-type antibiotic. And that one we give the dose of 500 milligrams 3 times a day for at least 2 weeks. Now, this is an important point. Again, we don't have good research evidence, but those of us who work in lymphedema clinics have seen a lot of patients who have treatment for 5 days or 7 days, and they get an improvement in their cellulitis, but maybe 2, 3, 4 weeks later it comes back again. And we feel that it's because it hasn't been fully treated in the first place. So we tend to recommend at least 2 weeks of antibiotics for all our patients who have cellulitis with lymphedema. And I say we have no evidence, but I think most of us feel that does seem to work better from our experience. That amoxicillin is a good antibiotic against the streptococcal bacteria. The alternative flucloxacillin works against the streptococcal bacteria, but it also works against the staphylococcal bacteria. So some guidelines in some areas of the UK recommend that. It seems to be as good. There is some feeling amongst us that you have more side effects from the flucloxacillin than from amoxicillin. And we also feel that it perhaps doesn't get into the fluid as well as the amoxicillin. What we are keen is that we have the right antibiotic that actually gets into the lymphedema tissue, and we feel that amoxicillin probably does that better than flucloxacillin. Again, there's not a lot of research evidence, but there is some that suggests that's the case. So the important thing is having the antibiotic as soon as possible. When I talk to patients of mine who have cellulitis or who have lymphedema, we normally talk about cellulitis and try and describe the symptoms as you have heard. And I usually say to them, if you have cellulitis beginning on Saturday, don't wait till Monday to get the treatment. Go and see somebody on the Saturday, because it can develop quite quickly. So some people end up in hospital for intravenous antibiotics, and this is really if people are very unwell, if the infection has made their blood pressure drop, or perhaps more commonly if people have had antibiotics by mouth at home and they haven't worked, the infection is getting worse. So then in the UK people are admitted to hospital for antibiotics. In hospitals have their own guidelines for cellulitis, for any type of cellulitis, and most of the hospitals in the UK use flucloxacillin as the main antibiotic, but in quite a big dose, sometimes more than that dose. And then people will have that for a few days until things are improving, and then they go on to the antibiotics by mouth, and then have a full course of at least 2 weeks altogether. That would be the way we would recommend. So, what causes cellulitis? When Neil was talking to you earlier, we were talking about things like injections and such like, and acupuncture, that you're concerned might introduce infection into a lymphedema area. And I think we feel that's the main cause, that some break in the skin is where the infection gets in, and obvious things like cuts, insect bites. A lot of patients report that infections have occurred after insect bites. Athlete's foot, this is a fungal infection between the toes. I don't know what you call it in Sweden, but it's the toes crack and it's itchy. Fine, good, thank you. Thank you. That may cause cracks and the bacteria can get in. And that's quite important with people with leg lymphedema, to try to watch for that and treat it to stop the cellulitis developing. And then other skin conditions which people may have coincidentally with their lymphedema, through breaks in the skin with ulcers or eczema or dermatitis, that can cause an area where the bacteria can get in. Ingrowing toenails, where the toenail grows in, that can cause infection and more problems with cellulitis. So there are things which you can try to prevent, to be cautious with, to try to reduce the chances of getting cellulitis. But sometimes some of my patients say to me, well, nothing has happened like that. I have my cellulitis and there was nothing wrong before. A few of them have had sore throats. And again, we haven't got good evidence, but certainly patients have said to me, it seemed to come on when I had a sore throat, and then I got the cellulitis in my arm or leg. And sometimes I have a number of patients who say, when I'm stressed, when I'm busy at work, or I have family stress, then my cellulitis happens. So I think there are lots of factors that can make it worse or more likely to happen. So one of the very important things for people with lymphedema and cellulitis is this risk of getting it again, getting it more than once. And in our survey that I mentioned earlier, of the 396 people that sent their questionnaires back to us, 76% had had more than one episode of cellulitis. Now, this may be a select group, because inevitably people sending the survey back were going to be very interested in cellulitis, particularly if they had repeat episodes. So that's probably an overestimate, but it still shows how significant a problem it is. And in those people that sent their questionnaires to us, people had an average of 1 point episodes per year in the previous year. Sorry. So why is cellulitis such a problem? Why do we get worried about the episodes? Firstly, and I'm sure I don't need to tell you that have had it, it's very unpleasant when you do get cellulitis. Sometimes it can be mild, but it can be very severe. It can make you feel unwell, and you can end up in hospital, and you can have time off work, and etc. And one of the very important things if you have lymphedema is that cellulitis damages the lymph vessels, and that can make the lymphedema worse. So the more cellulitis you have, the worse the lymphedema can become in terms of the swelling. So it's very important to try to reduce the episodes of cellulitis. There has been some interesting work done now we have a chicken and egg situation. You may have that term in Swedish, I expect, where we know that cellulitis can make lymphedema worse, and we know that lymphedema causes cellulitis. And some people who have cellulitis for the first time may then go on to have lymphedema. That may be the cause of their lymphedema, apparently. But what we now begin to think is that perhaps they had a lymphatic problem, before they developed the cellulitis. So maybe they had a type of primary lymphedema which was very mild. They then developed cellulitis because of that, and then they got worse swelling because of the cellulitis. And that pattern is something I think we're increasingly seeing in our clinics. So cellulitis is something we're really keen to try to prevent and keep on top of. How can you reduce your chances of getting cellulitis? Looking after the skin, taking care of the skin with moisturizers and making sure the skin integrity is good. I feel nervous talking about the skin. I have Professor Ryan here, who's an extremely eminent dermatologist, but I'm sure he'll add to anything that I say or correct me. But maintaining the skin's integrity is really important in this situation. And the other thing that we have learnt from research is that if you control the swelling in lymphedema, that reduces your chances of getting cellulitis. So good control of the lymphedema improves the risks, reduces your risk of getting further cellulitis or getting it at all. So that's really quite important. So what sort of precautions can you take as people with lymphedema? It's this balance, isn't it? It's trying to live as normal a life as you can with your lymphedema, and just minimizing the risks of problems. So how do you avoid insect bites? With difficulty, I think. Certainly I've seen a number of patients who, even though they're wearing a compression sleeve, the insects manage to bite through it, so that doesn't solve the problem.